Welcome to this Optical Express podcast. I'm Simon Whale, hosting a conversation with three very special guests. We have Professor Steve Schallhorn, Dr. Stephen Hannan, and Professor Julie Schallhorn with us today. We're at the latest and most spectacular Optical Express clinic in Great Portland Street in central London. First of all, I'd like to turn to Stephen Hannan. Stephen, would you like to introduce yourself?
Yeah, thank you, Simon. I'm Dr. Stephen Hannan. I'm Clinical Services Director at Optical Express. I've worked with Optical Express since 2002. Clinician by background and enjoy everything about patient care, have a really varied role, really driving and supporting our teams to deliver best-in-class care to our patients.
Stephen, thanks. And I've mentioned where we are today in this rather special place. Could you talk us through what this clinic is all about, the investment that's been made?
Yes, absolutely. So this is our latest generation state-of-the-art clinic, as you briefly mentioned. This clinic has had over £6 million invested in it, including the technology that we see behind us here today. The clinic provides latest generation laser eye surgery and premium presbyopia correcting lens replacement surgery for patients, as well as cataract surgery. Optical Express undertake over 60% of procedures, private pay procedures here in the UK. We are proud of our excellent outcomes that patients tell us about, that we deliver. We have clinics right across the country: Scotland, England, Wales, Northern Ireland, Southern Ireland, and further afield in Europe. And this is our latest flagship clinic here in central London, working in tandem with our Harley Street clinic, not that far from here at all.
Fantastic, great, thank you. And if you think back, you've been with the business for a long time. How have things changed? How is it now today compared to the way it was, say, 5-10 years ago?
Yeah, great question. So today we offer premium lens replacement procedures, still as we have always done, laser eye surgery and lens replacement procedures. Today also, and for the last few years, we provide care to NHS patients through our sister brand ACES. ACES is a brand that provides premium cataract surgery for NHS patients, glaucoma care, oculoplastics care, and general ophthalmology. The NHS in the UK is going through, or in England certainly, is going through a testing time through the course of the last 6 months and probably the next 6 months to 12 months. What we're seeing is really a restriction or downturn in the delivery of cataract surgery within the NHS. What we at Optical Express are seeing is some patients who have been informed of a delay in their cataract surgery, electing to proceed with private pay cataract surgery with us as a group, which is a benefit to us. And of course, the patient benefits from early intervention when they've got a condition like cataract surgery. It reduces their likelihood of trips and falls. It improves their quality of life by having that procedure done. Many of our competitors in the NHS side certainly will struggle with the changes that have went on. We are in a very fortunate position because of our strong private pay business here at Optical Express that we're able to invest in clinics such as this with the latest generation of technologies.
Stephen, thank you. We'll come back to you shortly, but we're also joined by two special guests who have literally flown in the last couple of hours from ESCRS in Copenhagen. Julie Schallhorn, Steve Schallhorn, welcome. Please do tell us a little bit about your own professional background. Julie.
Thank you so much. Yes, I'm a cornea cataract refractive surgeon from the University of California, San Francisco, professor of ophthalmology, and I'm on the medical advisory board for Optical Express.
Steve Schallhorn. I'm an ophthalmologist in San Diego. Been with Optical Express on their medical advisor board for almost 20 years.
Yeah.
So I've certainly worked with a team here for many, many years. My other hat I wear is I'm the chief medical officer for Zeiss Meditech, which is a large provider of medical devices and other things.
Steve, Julie, thank you. You're both on the IMAB, the International Medical Advisory Board of Optical Express. Could you tell us a little bit about the role of the IMAB and what you do on it?
I'm the head of the medical advisor board and have been running the medical advisor board for many years. So this board is made up of the top ophthalmologists from around the world that get together and provide clinical governance and oversight, direction, guidance to Optical Express in their clinical, their surgical, their patient care aspects. And so it fulfills a very important role for Optical Express.
Yeah, and I'd say I think it's really unique in that the IMAB, the Medical Advisory Board, really is focused on driving patient outcomes and deeply investigating kind of the factors that lead to those best outcomes. So I think it's provided great insight over the years, both for patient care, for improving patient outcomes, for patient selection, both within Optical Express and worldwide.
Well, I was going to say you share some of the research findings and the information that you gather as an advisory board globally, don't you? It's not just within Optical Express.
Yeah, of course. It's led to, I'd say, greater than 50 peer-reviewed publications, hundreds of conference presentations. It's some of the most widely cited literature, I think, in refractive surgery.
And it has evolved to where this data analysis, this diligence of looking at how well patients do after surgery has steered for better patient care, has steered for more efficient patient care over the years. So many of the things that Optical Express Medical Advisory Board has carefully evaluated over the years, as Julie mentioned, has resulted in major peer review publications that has changed the practice really around the world, not only at Optical Express. The driving effort is to improve patient care, to improve the outcomes.
And those articles, in many cases, many subject matters, are so powerful because of the size of the volume of the data. Many of the publications that we've engaged industry publications on, many of the articles really are greater than the sum of the parts of all the other articles on that particular subject matter. So it really adds strength to the community, not just to Optical Express and the patients of Optical Express, but further afield. And the medical advisors really take great pride in really advising the group as to the best opportunity for patients. What is at the heart of every decision is patients and the patient care that we deliver here at Optical Express.
I was thinking, Stephen, it must be a fantastic asset for you guys in the day-to-day work that you do to have a board with such expert leaders from around the world in it. I mean, how does it feel, and do you think you could get that anywhere else?
Yeah, without doubt, you can't get that anywhere else. It's a great asset for us to have as a business. It's a great asset for our treating ophthalmic surgeons and clinicians to have, really, to kind of have the foresight of a group of key opinion leaders within the industry that not only utilise their experience, but also utilise the benefit of the data of Optical Express and the patient outcomes that we produce. One of the background points which is critical to what we as a medical advisory board do is really our innovation and our effort we put into our medical record system, our electronic medical record system. That's unique to us as a business. It's an in-house system, but it drives not only best-in-class eye examination or consultation, but also outcomes. It allows us to capture such a wealth of data, both clinically and patient-reported wise, that allow medical advisors to really analyse and understand the outcomes that patients they receive.
The term, big data, it's a kind of a slang, just like AI, artificial intelligence slang. And I think when the community in general thinks of big data, they think of Optical Express.
And you two, of both Julie and Steve, you've got experience of other providers, both here and across the world, particularly in the US. I guess that the use of data, I'm going to call it data, by the way, not data, but that's just me. The use of data and the extent of it that Stephen has mentioned, how does that compare to your experience of other providers?
It's anywhere that sees patients generates data. It's how that data is stored and how it's structured and how accessible it is. And Optical Express, 20 years ago, really had the foresight to create a very structured system for storing patient data, which makes it now easy to go into that system, pull out the data, extract the data fields, and be able to analyze them. Yes, every provider generates data. And, if you combine all the patients in the world, there's massive amounts of data. The issue is that, most of it's locked away in paper charts, half of it's locked away in fields that are not coded, that, you have to go through and manually recode them if you want to analyze it. And, that type of data structure is fine if you're looking at a rare disease, you're a single clinic, you're seeing patients with very unusual things, and you can go through and manually review those charts. When you're talking about something as common as, refractive surgery and cataract surgery that affects everybody in the world, you really need to look at a lot of people to be able to get those outcomes analyzed. And that's really the power of the OE, electronic medical record system.
And also, Simon, getting to your point too, many practices around the world are now trying to emulate the legacy of what Optical Express has done. In other words, the value of getting that data assembled, readily available, so you can look at it. When I say data, I really mean, patient outcomes, patient-specific information on how well people do with a given procedure or a treatment, those type of things. And so I would say they're emulating it. They want that. They want that
Great
data.
Isn't it? Stephen, you mentioned ACES, which sits in alongside Optical Express, providing NHS care. Yeah. How are you approaching the collection of data for ACES?
In exactly the same way. So we're using the same medical record system, obviously separate groups and separate treatments. We've expanded the medical record system both from a clinical and patient-reported outcomes metric perspective to capture the additional and vital pieces of information for those different specialities. Glaucoma is a condition that can cause severe damage to patients. It's really important that intervention takes place at the right time, the right intervention. And we're capturing the key metrics for that condition, which are different than the next condition, etc. So we're really homing in and focusing on the eye and the eye condition and using our framework medical record system to really allow us to publish and analyze data outcomes, patient-reported outcomes. How do we benefit the patient is really what we're getting at through our data.
Yeah, and I think that's going to be transformative because, with the power of that electronic medical record system, we're going to really be able to start asking, deep questions about patients that really have, blinding, truly blinding eye diseases and start to develop, and uniquely actually from the patient perspective, what's working for them.
Really exciting stuff, actually, as it builds and builds. Yeah. Let's look at some of the services and procedures that Optical Express offers. Obviously, laser eye surgery is at the heart of what OE does. Yeah. This is for all three of you, how do you think technology has affected, improved laser eye surgery in, say, the last 5 to 10 years?
I mean, it's really just, it's come down to better diagnostics and better, treatment patterns. And I think that, we last, published our LASIK outcomes, is that like 3 years ago? And they're just astoundingly good. Yeah. Actually with the new, the newer refraction systems, really, really impressive.
Yeah, I mean, when we look at our range of treatments, we look at them in several different ways. If we focus on our most common prescriptions that we treat, over 99% of those patients achieve better than 20/20 vision. It's really fantastic levels of acuity that patients are seeing today. Such a small proportion of patients require that second treatment that maybe a number of years ago was slightly higher, maybe 5 times higher 5 years ago than what it is today. Today, a fraction of 1% of patients will, in that most common prescription group, will go on to have a second treatment to correct their vision. As Julie mentions, technology really has advanced to the point that outcomes are fantastic for those patients.
Does it also mean that more people are suitable candidates for laser surgery?
It's an interesting question. I think we as a group are quite conservative in our suitability guidelines. We spend quite a lot of time as a medical advisory board really deciphering who do we want to offer laser eye surgery to. And I guess we think of that friend or family member when we make each of the decisions to really determine, do we want to offer that patient laser eye surgery? There's a wide range of patients that can have laser eye surgery. And of course, there's a small percentage of patients that still today cannot have that procedure offered to them.
It's interesting that your primary objective is to make sure that this is the right procedure for them, that it's not just something that you want to maximize.
Yeah, I mean, patient comes in, we want to know what's the best procedure that can address their issue in the most effective and safest way. I think that sums up a lot of the analysis that gets performed, a lot of the thought, the diligence that goes into the medical advisor board and certainly Optical Express and the implementation of it.
Because, you know, from my mind, it's not about, you know, selling a patient a procedure or, you know, getting them to do something. It's, you know, what is the best option for you? You know, what is going to give you the best outcome? What is going to give you, you know, the most satisfaction in your life? And we are really lucky actually to be able to ask those questions and to develop answers to those questions.
Yeah, it's got to be the right treatment for the right patient. We've declined over 1 million patients. We've declined laser eye surgery across the last 20 years through really our diligence as an entity at providing best-in-class care to the patients, providing that advice that we would want ourselves as individuals if we were the patient.
Let's turn to cataract and lens replacement. How have things changed in that practice area from your perspectives over the last 5 years or so?
Well, I think, you know, first getting to the whole concept of, you know, how things have changed, thanks to providers, thanks to manufacturers, thanks to, you know, the industry, this progress goes only in one direction, that's positive. There's improvements that are continually being made. Laser vision correction, definitely. In the treatment of diseases, chronic diseases like glaucoma, significant improvements, or diabetes. In the for lens replacement, for cataract surgery, again, enormous improvements have been made and will be made going in the future. So right now we're at just an unparalleled level of effectiveness and safety when we talk about taking out the natural lens in a patient's eye and putting in another lens, a very special lens in it. It's just unparalleled. Never before in human history has this been so successful.
So those lenses that are used today, I guess, are completely different from lenses that would have been used 10 years ago in terms of the effectiveness?
Well, I would say they're completely different than the lenses we were putting in 30 years ago. They're significantly different than the lens we were putting in 20 years ago. They're quite a bit different than 10 years ago. So there's incremental improvements in this in almost every way. I know right now at Optical Express, they're just, you know, they put in state-of-the-art lenses. These are phenomenal optical devices that are placed in the eye.
And we're sitting in a clinic which is full of the most recent and high technology for patient care. What do you think the future holds? What's next in terms of the development of technology in eye care?
Yeah, I think, well, touching on the lenses we've got today, phenomenal improvements, as we touched on, in terms of, through the course of the last few years, in terms of the range of lenses we've got, whether it be astigmatic corrections and the stability of those treatments to correct long-term, whether it be designs to correct far, intermediate and near vision. If we think of the patient of today, you know, intermediate vision today, patients are so reliant typically on intermediate vision. We regularly engage patients that use a device at an intermediate distance, 65 to 80 centimeter type range today is quite commonplace. You know, 15 years ago it was rare to get a patient who said they didn't drive. Today, it's rare to get a patient that says they don't use the device at intermediate vision. And I think our technology has really advanced thanks to industry and efforts of groups like Optical Express and the data that we have. We work closely with industry and many of the key opinion leaders across different providers to really help shape the lenses of tomorrow. You know, I think undoubtedly, as time goes on, AI will play a bigger role within ophthalmology and in areas like the selection of the type of lens best suited to the patient. You know, today's lenses are fantastic. Fine-tuning that algorithm of which lens is best for a patient will continue to evolve. Lens designs will continue to evolve. Treatment will continue to provide that slightly incrementally better outcome. I say slightly incrementally better because today's outcomes are fantastic for patients. Therefore, there is a little bit of room for further improvement, but it is a little bit of room. Today's technologies really are delivering fantastic outcomes.
Yeah, and I think another area that Optical Express is actively investing in is really telemedicine.
Yeah.
And the ability to connect with patients that may not be in a major center, or it might just be a hassle for them to get there.
Yeah.
so that they can go somewhere that's easier and actively really looking at the predictors and the outcomes of that approach.
Totally right, because I guess what we've aimed to do through the course of the last few years through embracing telemedicine is really increase the accessibility of care to patients. Not every patient stays in a major city where there are choices for their eye care. What we've got across the UK is a unique model that allows us to provide care to the patient within their local community. And that doesn't necessarily mean the clinicians are in that local community. That means we've got access centres close by to the patient where the patient can go in, and we as an organisation, through our skilled clinicians, can utilise today's technology to provide that best-in-class care, even if the optometrist or the eye surgeon is not in the same location as the patient themselves. Through today's technology, we've got such high detailed capture of diagnostic scans that allow such great assessments of all structures within the eye. We can measure a patient's vision remotely. We can measure an eye prescription remotely when the clinician and patient are not in the same location. And really, what we've invested in there is really providing care to patients locally, which we're seeing patients are welcoming.
Yeah, and I would say the really the powerful thing with Optical Express, with the electronic medical record system, and also the willingness on the part of OE, is to really analyze that and make sure that it is good for the patients to be able to do that, and the outcomes are not going to be affected by that. So it's really an impressive thing.
Yeah, and that, you mentioned patient-reported outcomes. It's as much about what the patient thinks of the outcome as it is about what the data says.
Yeah. Well, I think that's the most important outcome. Barring obviously complications or whatever, what the patient really perceives their vision is really a bottom line. It's very critical, and it's treated as such.
Yep. Determining that patient's lifestyle, analysing it in detail to understand what does the patient do, what does the patient use their eyes for, what does the patient do in their spare time and work time, really allows us to recommend to that patient. And it's totally agree with Steve that patient-reported outcomes really are the dominant force in really understanding satisfaction and really understanding how effective are the technologies we've got available to us today.
So we touched a little bit on the potential of the development of technology and clinical skills, and you've talked about incremental progress, meaningful incremental progress. I'm going to try and tempt you to look further into the crystal ball, each of you, and just think about the next 10 or 15 years. What do you think might be possible in terms of eye care in 10 years' time or 15 years' time that isn't possible today?
Well, one of the areas is in the management, diagnosis and management of patients who have chronic eye diseases. And these are patients that have really eye conditions like glaucoma or diabetes. And so it's undergoing and will undergo a revolution in our ability to really better treat, better manage those type of patients and offer more effective treatment for people who have really got some ocular disabilities. So that's one area that I think there's a lot of effort going across the board, industry and obviously providers to tackle patients that really have really chronic diseases of the eye.
I think another area is really in patient awareness and education. I think, we've got such great solutions for whether it's vision correction, whether it's treatments of eye disease, but that patient, that member of the public has to really understand, how do I access that care? How do I achieve what is possible? We as clinicians sometimes understand the mechanics of a solution, but does the patient that can benefit from that solution, really, do they understand it? And I think that key element moving forward across the UK and further afield is really ensuring patients understand what their options are. What are their options with vision correction? What are their options with intraocular lenses? What are their options if they've got a cataract? What are their options if they've got glaucoma that can treat them? How do they become less reliant if they've got glaucoma on eye drops, for example? How can we improve the quality of their life? That to me is a big piece of work that we've got to all educate the general public on of their options of vision correction and eye care.
So I guess we see care becoming more personalised in the eye care space, as it will be in other medicine disciplines as well. But that personalised, tailored care based around the individual patient is something that we can see leaps and strides in the years ahead. Yeah, fantastic. Okay. Obviously, in the UK, we've got huge cataract backlogs. There are many, many patients who are waiting far longer than they wish to for their cataract procedures, and indeed other eye care procedures. How do you see the ACEs and Optical Express offer, and how can it help deliver those patients some timely care, which they're not currently getting?
Great question. And I guess if we look across the UK, the UK is, as we know, made up of several countries. And when we look at the healthcare systems across those countries, there's a postcode lottery or disparity in terms of the care we provide in something like cataract surgery. So until recent times in England, for example, patients who had a cataract were able to have a cataract procedure to improve the quality of their life, reduce the risk of trips and falls within 4, 5, 6 weeks. That time is now being stretched and pushed out, driven by decisions of NHS England and the powers that be as to really involving a funding matter, Simon, rather than actually a clinical matter. Clinically to the patient, the earlier the cataract patient is treated, the better their outcomes are from different perspectives, from their perspective, and also from a safety perspective. But that's been pushed out. It'll be 14 weeks, 16 weeks, 18 weeks, 20 weeks before we know it. It'll be the norm in England for cataract surgery between referral to treatment. That process is already taking place. What that's going to do is make the viability of the service for certain providers more difficult. We're in a fortunate position at Optical Express and ACEs that we've got a large private business. We deliver over 60% of eye surgery procedures for vision correction on the private side across our clinic network. What we're going to see is more patients turn over to the private side. When we look across the countries, England, as I mentioned, current time 4, 5, 6 weeks, that'll push out to 18 weeks, 20 weeks, 16 weeks of that ilk. We look at Scotland, many areas are over 12 months. Look at Northern Ireland, many areas of Northern Ireland over 5 years from referral to cataract procedure. The disparity across the UK is huge on the NHS side. That means patients have to make choices and spend their funds, their hard-earned funds on their self, their eyes, their vision correction. We're here to really make the service accessible, whether it's private pay or whether it's NHS funded, across each of the clinics, across each of the different treatment lanes we deliver on, whether it's cataract, whether it's glaucoma, whether it's general ophthalmology care. Really, we want to make care accessible as possible to patients.
Yeah, I mean, the waiting times of 12 months or 5 years is just extraordinary and very alarming, isn't it? Steve, Julie, are there any lessons that can be learned from the way that capacity is managed in other territories? I'm thinking not just of the US, but your experience more widely.
It's a challenge. It's a challenging environment. It's certainly challenging here. It's really challenging all over the place because you have in the US reimbursements for cataract surgery going down. You have national health services really across the world, being tight on budgets. The considerations there. So you have this downward pressure, which increases wait time. And this is almost a fact of life. So from a provider perspective, you want to deliver that care despite that downward pressure, and you want to deliver better care. So those are diverging pathways. In order to manage that, you really have to have latest technology, understand what you're doing, have good oversight, have good clinical support to be able to manage that in these difficult times. And I think, obviously having that mix as you have is enormously valuable.
Yeah, I'd say, efficiency with total attunement to patient outcomes is really the critical thing. Looking at increasing efficiency, and this is going to be a worldwide problem because of the way the population is aging. Increasing efficiency while improving patient outcomes is really the critical thing there, and it's a tough thing to do. It's not an easy challenge.
I wonder whether that's slightly easier in the independent sector as compared to in this country, the NHS. That ability to improve efficiency, as you say, Julie. Are you just more nimble in the independent sector than the NHS can be.
Yeah, no, absolutely, and I think with the same team members and the same type of patient, same grade of cataract, organisations like ACES and others are more efficient in the delivery of service, which means we can ultimately care for more patients within the same period of time, while the surgeon and teams use the same amount of energy to deliver over a given period of time more care to patients. And really that is a key focus. I guess if we think, Simon, of the independent sector and its delivery of cataract surgery pre-pandemic to today, 63% of cataracts are done in the independent sector by the big 5 independent sector providers that ACES are one of.
So those are NHS patients being treated.
Yeah, NHS patients being treated in private care, and that was 10% of the total NHS funded cataracts prior to the pandemic. I think a key point in terms of the delivery of cataract surgery in the UK is if you compare to many other European countries, the penetration per head of population is lower in the UK than where it is across many other European countries. So we're doing less surgery per 100,000 head of population in the UK than what we are in what has been taking place in many other European countries. And I guess question for Julie, you in your practice when you're in and you're delivering clinical care, deal with a lot of complex patients that you see that are referred to you through other doctors because of your speciality focus in that area. What do you view as the downside of a patient with a dense cataract waiting longer? What's the downside to that patient? What's the potential impact that has on their ophthalmic care to you as a surgeon and to the patient themselves?
Yeah, I mean, it's if the patient can't see, obviously it's detrimental to them in many ways. Technically speaking, it takes longer to take out a patient with like a very, very dense cataract, and it requires like more energy, and depending upon certain factors, the risk of the patient can be higher in terms of complications. So agree that leaving cataracts until they're and this I think this term has mostly gone by the wayside, but occasionally I'll still get patients in there that like well, my doctor told me they're not quite ripe yet, and they come in and they're 20/50 with like a 3+ nuclear NS cataract, but they just got a PSC, but you can tell the nuclear sclerosis has been there for a while, and they're getting glare now with their PSC, and you're like, we don't really use that term anymore. It's it's when it starts affecting you. I always tell patients, like, if your cataract is bothering you, then it's bothering me. That's when it's time to take it out. Or if you legally are not going to be able to drive anymore, then I have to insist that I take it out.
That's a really good perspective. Yes, and just the Stephen, also to your point about when you lose vision, and you certainly reach that point with a very opaque cataract, you lose vision. You lose so much of certainly the quality of your life, but also the safety aspect of it. You mentioned a fall, not seeing a step. Those type of things have real impact that have been really studied and are really critical for us to look at. It's important for people to know that those are really important factors that can detrimentally harm patients and the public in general.
And there's some really good literature, and people can debate this, but there's some really good literature from actually multiple countries now looking at the risk of dementia with untreated cataracts, because the visual input provides so much stimulation to the brain that if you decrease that, you actually have a greater risk of dementia. Now, people go round and round and argue kind of whether or not that's a true effect, or if we're seeing an effect of people not getting cataract surgery, but the link is there, and the link is pretty strong. So it's definitely something that
So the impact of delay I guess is way beyond the eyes. Is what we're saying. It's way beyond vision. Is a significant impact. I chatted with a patient earlier today, actually, who was in one of our clinics for cataract surgery. He was there with his wife. He'd been under another eye care provider for 10 years for another eye condition which he's got, which is stable, and he had decided he didn't want to wait on having his cataract surgery done. He decided to go privately, come to Optical Express, asked them why he'd chosen ourselves, and it was a recommendation from a friend who'd had surgery done with us. I asked him what was he looking forward to doing in the month after surgery. And what he said to me was he's looking forward to driving his family around. His family are not getting in the car with him at the moment because they feel he's unsafe to drive. He's looking forward to drive them. That's simple. That's exactly voting with their feet. That's simple. That simple thing, such an everyday occurrence that sometimes we forget about, is really can have a massive impact on an individual or their family. So I think that's a huge benefit that we offer patients as early intervention.
I do want to say something though, Stephen, because I practice in the U.S. in a big university, which does have like delays in care as well, and I just want to say that, because the NHS physicians, I know several are really good physicians who are working really hard, and they are not choosing to delay these people's surgery by any means. It is it is a sad and unfortunate effect of the system, and I know that they are fighting against it and trying to advocate for their patients. So I do just want to be clear that I have immense respect for the physicians that are practicing in that system, and I know that they are doing their very best for their patients.
I think that's a really good point. The other thing I would add too is that no other procedure in the history of mankind has had such an enormously positive impact on humanity as the cataract procedure.
Cesarean section. Just kidding. I put that out there too. There's two. But that's different podcast.
But you're right, Steve, in terms of transforming lives, restoring 20/20 vision or better, whether it's cataract or indeed IOL or laser, these are transformational experiences, and I know all of the testimonies from patients point to that they feel their lives have been given back to them, and it's, compared to many other procedures, it's relatively straightforward and it's relatively quick, but the effect it has is profound. Just coming back to the point about those hidden costs of delaying surgery and the link to dementia and the clear evidence that links trips and falls to poor sight. Do you think that payers in the UK context, the NHS, appreciates and understands that and acts on that?
It's a good question, and I think it's something that's not well measured in terms of the other impacts of not treating a cataract early. Whether it be trips and falls and trips to orthopedic, whether it be mental health, whether it be conditions like dementia. There's many studies, many publications now that, as Julie touched on, link the eye and the inability of the eye to provide clear vision to another condition or another incident that occurs that impacts and actually costs significant multiple times the cost of a cataract procedure to the NHS. So it's a key area really that UK healthcare really needs to focus on and understand.
But doesn't really focus enough at the moment.
Doesn't focus enough at the moment.
Right. Optical Express and ACEs, growing businesses. You need more clinical teams. You need more surgeons. Tell us, Stephen, why should a surgeon join Optical Express?
Well, I think first of all, medical advisors like we've got really provide insight and guidance and facilitate best level of care through the teams we've got. As an organisation, we've got hundreds of clinicians across the UK. We continue to grow. We continue to therefore really seek out that high quality clinician-led delivery of care that we provide at each of the centres. I think it's important to say that like with all surgical procedures, there's vast benefit and there's a potential risk, which we go through with every patient ahead of surgery. With our lens replacement patients, doctors today speak with patients via multiple mediums, telemedicine and clinic, ahead of the day of surgery as well as on the day. Our outcomes are fantastic. We've got high demand. I think, for clinicians today, you work in a system at Optical Express and ACEs that really is allowing you to develop your skills. Today, if we think of optometry, within Optical Express, we have optometrists that deliver YAG capsulotomy procedures, that deliver SLT procedures. These are procedures that only a few years ago were really only 100% delivered by ophthalmic surgeons. So we're really changing the delivery models within optometry and ophthalmology to benefit not only the patient, but also the clinicians that are part of our group. So we encourage clinicians who want to really develop themselves clinically, whether it be through additional qualifications optometrists, independent prescribing, glaucoma qualifications, whether it be through ophthalmologists that want to specialise in premium pay presbyopia correcting IOLs, to really come and join us and chat with us about opportunities that we have across the group.
I want to finish by talking a little bit about the group's charitable endeavours and the philanthropic work that the group has been doing for some years now. Some of that is focused on environmental concerns that Optical Express has. Do you want to talk us through how that's manifested itself, what the group has done in that space?
Yeah, absolutely. I think it's the hidden secret that sometimes we don't share as much as we should, Simon. I think, we've donated as an entity, as an organisation, through our founder and his efforts and efforts of the wider team. We've donated over £36 million across the last 35 years to charitable causes. Will be £37 million by the end of the year. I guess recent example, we are now on our fourth iteration of a campaign called Thanks a Million, which is basically where we gift £1 million of eye surgery to certain industries, healthcare workers, for example, NHS. We're going to be launching later this year as part of that project an offering to veterans to really come to ourselves to receive free of charge surgical procedures, really. So I think whilst we are a very vibrant business, I think we do spend a sizable chunk of time within the organisation really thinking how can we give back to the public to benefit the wider public and certain populations within the group. So we've got a range. We've got a philanthropic arm that really provides a charitable organisation that really provides care to those who need it most across the UK and Europe.
Yeah, it's wonderful stuff. And I just want to highlight the environmental work as well, because I think it's fair to say Optical Express in the UK has led the way in raising awareness about environmental impact of eye care.
Yeah, and I think a key area in that, Simon, is really the delivery of how do we deliver care. I guess we like to educate our patients and the wider patients about the risk of contact lenses, for example, and insofar as the disposal of contact lenses. Unfortunately, a proportion of contact lens wearers dispose of their contact lenses in a way where they end up in the oceans, for example, which can be damaging to the marine life and future populations of human ourselves. I think we've educated patients on that and really focused a bit on digital. How can we reduce the need for the patient to travel to a clinic for eye care? How can we make that same level of care? How can we deliver a high level of care the same as the patient travelling without the patient travelling, whether it be by teleophthalmology, telemedicine? We've really spent a kind of effort working on and continue to do so on really delivering a pathway that enables us to leave a lower carbon footprint than what we did in the years gone past.
Great. And I just want to ask Julie and Steve, when you think about all the different aspects that you've got involved in through the advisory board of what Optical Express and ACES do, what do you think has been most impressive to you? What's the thing that, if you could name one thing about the way that the group does what it does, the technology, the data, whatever it is, what's that one? Is there one standout thing?
Yeah, I'd say, for me, it's really the unflinching, nature which Optical Express looks at its outcomes. Yeah. A lot of, I think there's a tendency for all of us, to be like, oh, I'm doing a good job. But that's not really what OE does when it looks at its outcomes. It's like, who is doing well, who is not doing well, why are they not doing well? Yeah. Why did we've got great outcomes, but there's 1% that's not doing well? What is that? Like, let's really drill down into that. And I think that that's impressive. That's really impressive to me. And it's been honestly transformative for the industry.
I think almost building on that, because I agree, and I call it continuous quality improvement. That it's never rest on the laurels, right? Yeah. It's never good enough. And that has been the consistent theme through every medical advisor board meeting we've ever had, is here's where we're at. And Julie, to your point, how can we do better? What can we do better? How can we improve the patient experience? Yeah. How can we improve patient outcomes? How can we improve it? You name it, right? You name it, the practically, the Medical Advisory Board has looked at it, and many of those times we've published on it, and that those publications have, some of them are sentinel publications that have changed the practice of medicine around the world. Again, that's the power that you've got, right? That's the power of the Medical Advisory Board.
Well, we'll look forward to more strides for the future in terms of patient outcomes, patient care, evidence and data. But for now, Steve Schallhorn, Stephen Hannan, Julie Schallhorn, thank you very much.